Dr. Peter Noël here, board certified veterinary radiologist. Looks like we got 21 that have joined us. So I think that's a good place to start. I know a lot of you, I'm based on the East Coast of the United States. We had about 100 people that registered for this one, and they kind of scattered the globe. A couple of things, maybe do some housekeeping stuff to start, and then we'll kind of move forward. For those of you that haven't joined us before, I think it's important just to quickly go over the format for how I think you can best extract sort of practice and some information from this podcast or live stream. And so what we're going to do is there's probably going to be a mixture of cases off of our company's work list that I haven't seen. I think that keeps it kind of interesting and fun. And so those won't have known outcomes. Other cases will have known outcomes, but they're cases that I saw either today or maybe yesterday. And so this is a free, it's for you. And so the intent is for you to try to just squeeze as much value out of it as you can. I think the way that we present them will be very, very helpful. So I will pull up the study. I'll kind of flip through to show you how many radiographs we have. Just for the interest of this format, I'll probably try to find studies that have 3 or maybe 4 radiographs, so we're not flicking through a bunch. And then I'll tell you the history, and then I'll pause and I'll give you a period of time. And I think it's that period, that delay, is critical for your learning and where you can form an opinion. And I think that's the difference between trying to watch this sort of on demand after the fact or have this spoon fed to you through other modes. I think once you commit to trying to identify something as normal or abnormal, and whether that's just in your head or you write it down, or perhaps the best way is you type it into the chat so that you really are sticking your neck out, I think that's when you start to learn. And I think that's the difference between joining live and just having me talk about pneumonia and pushing it. So the interaction is really helpful for me. But I think it will also help you because there are things that you're going to see that maybe aren't normal that you'll perceive to be abnormal. And I can kind of help you decide. And you just have to tell me kind of what you're looking at. Briefly, I haven't done this in the past, but the workstation setup. So there's a series of things that I think that you need to be aware of when you try to interpret radiographs, whether you're at home or in the clinic. So firstly, the room's got to be dark. They say full moon, not pitch black and not too bright. If you have any lights, they need to be off axis, so indirect lighting. I have a very bright monitor. So I have a MacBook or an iMac Studio display, and I have the brightness turned all the way up. So you want a really bright monitor. You want a dark room. The lights in the room need to be sort of indirect or not directly shining at the monitor. Resolution is starting to be kind of a moot point because monitors are so nice these days. I don't think a lot of you are probably dealing with low resolution monitors. And the size. So I think, size does matter. And I read on a 27-inch, that allows me to see multiple views with one on one monitor. You don't necessarily need that by any stretch, but certainly something, in the 20s could be helpful. But brightness is really critical and sort of a darker room. So if you haven't done that, or, you're not doing it now, maybe dim the lights or tell the kids to stop screaming in the next room. Is it hard on your eyes to look on a full brightness for a long time? Yeah, that's a good question. There's something called you get like soft copy. I think it's called like soft copy review is what they talk about it in humans. And so you can get headaches. You just flat out start, hallucinating or making mistakes. And so what our company does, what we do is we do shift work. So we try to keep it at 3 hours. And so we try to go and get through as many cases as possible in a quality manner and then take breaks. And truth be told, I can't even usually make it to 3 hours. But doing that shift work, breaking it up, allows me to get out and not, either fall asleep in the dark room or strain my eyes. Let me put these up. So one other thing that I think was kind of cool. I don't know if any of you have heard of IMAIOS. So it's this website. It's got a human and a veterinary side. So I use this literally almost every day. And it's a compendium, or it's an atlas that has tons and tons of, I mean, endless variations on anatomy, and they have a lot of correlation with imaging. Some of it is, can be heavy on CT and MRI, and so you folks may not find that beneficial. But as a vet student, I would have loved it because it does all the muscles, and it's a really great. It's very interactive. I love it, and so I reached out to these folks and I said, "Hey, do you guys want to sponsor this or throw us a bone?" And so what they did is they've given us a couple of free annual subscriptions, and so now I got to figure out how to get one of you on this show tonight to get that free subscription. And so, not to sort of dupe you into sticking around, but at some point later, I think I've got an idea for how we can get a brave soul to get the chance to get that free subscription. Really quickly too, Roentgen signs. You could try to write these down. So Wilhelm Roentgen, Dr. Roentgen, he was a German physicist, and he detected first person to detect these X-rays. And so we use these things called Roentgen signs to describe normal and abnormal things. So sometimes we get kind of lazy, and I don't describe every Roentgen sign about every abnormality. But I think, as we'll show you on a few studies today, it's important to keep these sort of by your side if you're not used to using them, because while there are certain studies that you look at and you go, oh, that's pneumonia, oh, that's pneumonia, oh, that's heart failure, there will be studies that you pull up and you go, I have no idea what the hell's going on. And it's slowly going through these Roentgen signs that will really, I think, help you sort of start to narrow things down. Can you tell I had some free time? I'm messing with these banners. Okay, last one. If it's not implied, the opacities. So in order of reduced opacity to more opaque, you got gas, fat, soft tissue / fluid, mineral / bone, and metal. Every episode that we do is being sort of recycled and pushed to YouTube. I don't know if you guys have found that. There's maybe 50 subscribers, which for me is amazing. I'm not looking for ad revenue or going viral. What I'm looking for is helping veterinarians be able to better diagnose disease, help patients. It's critical for me that it doesn't cost anything, because I think there's a lot of people making money off of this these days. And so I think free, useful knowledge is great. So I think if you plug this in, or if you just search my name and put DVM DACVR, it'll pop up the channel. So this will go in maybe a couple of days after we push it tonight. So, all right, without further ado, let's party. First case is maybe we'll start. I'm not going to say whether we're going to start easy or more difficult, but I'm going to start with a known case. Okay, so we've got 3 radiographs: right lateral, left lateral, and a VD view. This is a middle-aged dog that has presented for coughing. Anybody have anything? Right middle lung lobe, infiltrative alveolar pattern, pneumonia. These are the folks that are always showing up. My hope is that, you don't have to come every time, but if you start coming, you feel maybe slightly getting better. So I don't know if anybody needs any more time. So again, I think the real critical thing is attempting to diagnose it yourself, because you will start to pretend that you see things, make things up. You'll think there are certain diseases there and they're not. And so it's your opportunity to try to have me tell you why I don't think that those things are there. Okay, so some of the things coming in, the heart enlarged. There's maybe a concern about pleural fluid. So here's what I see. So a couple of things. The dog is very well positioned here. You see the spinous processes here, the thoracic spinous processes. They look like teardrops. Very nice. He's rotated, right? So these ribs are offset. Not surprised he's rotated. He's having a trouble breathing. And he's slightly rotated. A little bit better on this side. So the way that I would interpret this is I'd say the cardiac silhouette is normal. The pulmonary blood vessels right here are normal. The cranial mediastinum is normal. The pleural space is normal. Now, there may have been a concern about pleural fluid because you see this thing and you're like, well, there's that. And then maybe that is what, Graham, I don't know if that's what you were thinking about. The reason this dog doesn't have pleural fluid is there's a couple of things. So right here, you see this line, you see this little triangle of love, this little triangle of fat. So we talked about this last time, but the reason that you can see that, the whole reason you can see this triangle is because this opacity, and that opacity, they're all different. And so differential attenuation of the X-ray beam comes flying through the patient. It's differentially attenuated based on things like the density and some of the physical properties of the tissue it's hitting, and then it's collected on the detector. If the reason you can't see carotid arteries, the reason you can't see blood, the reason that we don't call it the heart and we call it cardiac silhouette are because fluid and soft tissue are the same, and you can't differentiate those. The reason I can differentiate these is because it's something different here. If we know this is liver / diaphragm, and if we know this is cardiac silhouette / pericardium and stuff, then this has to be less opaque. And it doesn't look as black as gas or as radiolucent as the lung. And so it kind of looks like maybe the next one. So fat. So if this had pleural fluid, I would kind of lose that. I'd lose that area a little bit. I'd lose that little triangle. And then, boy, you got the triangle down here, and I can see all the fat here, and I can see the margin. You can see the soft tissue fluid margin because it's bordered by fat. So you go, wow, I don't think there's anything down here. And then you go, okay, maybe there's a little bit here, but this is a lobar sign. So this patient has right middle and probably a little bit of left cranial lung pneumonia. So where you should be looking for pneumonia is over the heart, because it's easy to lose it because it's sort of superimposed with the cardiac silhouette. So this, if I put these two radiographs up side by side, so you've got this view and this view, okay? So this one, you see it's gray. There's a opaque line right there, but that's a blood vessel, rib, gray, line, but it's all gray. Here, it's just a little bit more opaque. And then if you look closely, you've got the trachea or the trachea for those of you that are just a little different than me, which is fine because different is good. You got a left lateral view. So this is the right middle lung bronchus that peels off the carina right here. That's the right cranial lobar bronchus cruising through there. So it comes down here and then boom. So this is an air bronchogram. So definition of an alveolar pattern, there's a couple of criteria we use. Air bronchograms. So there's pus that's just filling up all around these airways. A lobar sign, which is what's creating this very sharp margin right here, is also something that we like to talk about with alveolar patterns. And then it's obscured the blood vessels. So blood, pus, fluid will all make this look like this. This is pneumonia until proven otherwise. If you're in Santa Barbara and you have the benefit of vacationing and you're on the beach, those patients like to get inhaled foreign bodies. Inhaled foreign bodies, in my experience, because I read for a clinic, we have a clinic in Santa Barbara. They like to go caudal and dorsal. There's pleural fluid. It's a nightmare. It's chaos in those dogs' chest. So this is right middle, maybe a little bit of right cranial lung pneumonia, a little bit of aerophagia, and that's it. The cardiac silhouette. So one of the reasons that perhaps somebody was worried about the cardiac silhouette being big is I wonder if they looked at this right lateral view and they go, this looks like the caudal waist that's gone. But you got to be careful because this rib, it'll do it to you a lot. Okay, so let's just say you were like, I can't tell. This is the rib. This is the left atrium. I don't know. Well, if you flip the dog over, you go, wow, man, this is kind of tucking up nicely. I can see that rib right there. And now I'm not so confused. And you go, okay, so now it's telling me one thing on one view and not another. And then if you look, you've got the trachea, and you do have to hallucinate, but it's right here. It's right here. And watch what happens. Right cranial lobar bronchus. Okay, right caudal lobar bronchus. Left cranial. So then that cowboy, cowgirl, whatever sign where you've got too much opacity from excess soft tissue from the enlarged left atrium, it's not there. So you go, wow. So 2 of the 3 views. Could I explain this as not being real? It's the rib, and you go, boom. So I think that's, I don't know if that answers your question about the heart. I think the cardiac silhouette is totally normal. Sternal lymph node enlarged or normal. I think the sternal lymph node is normal. I think that's probably fat. It's tough right here because the limb's over there, but I don't get any widening here and I don't get any widening here. It's been reported that on a right lateral view in particular, sometimes in larger breed dogs, you can have a sternal lymph node that's visible in health. So normal, you see it. And so sometimes I don't get very excited about this on a right lateral view, especially with the thoracic limbs pulled caudally, especially with this degree of back fat And then if you look here, the next thing you should do is look here and you go, this looks nice and fat. I don't see any fluid or anything like that. Cervical vertebral spondylitis, not related to coughing. This right here, transverse processes. This is the ventral lamina of C6, the sleds. Surgeons love that for ventral slots. End plate. These look good. So I don't see cervical spondylosis deformans. We call it spondylosis deformans and not spondylitis. I don't, itis is very inflammatory. And so we say cervical spondylosis deformans, but I don't actually see it. I think these are transverse processes. Doc Rach is worried about subcutaneous mineral and dorsal thoracic. So I feel like I see this a lot and have gotten to the point maybe where I don't comment on it. So this mineral structure here, left lateral view. Oh, I wonder if she thinks this is calcinosis cutis. I think this is a skin fold. I think these are skin folds. They're not as, I think it's one of those things where it does look mineral. So I give you that. It probably looks opaque because it's bordered by gas, because it's a skin fold, because he's obese, because he's American. And so I think that, I don't think the dog has calcinosis cutis. Oops, right lateral. Yeah, maybe you're talking about this. The dogs get injections right here a lot. So I feel like I do see some things right here that are injection related, dystrophic mineral from repeated injections, but I don't know. The liver is not particularly big. Those hyperadrenocorticism dogs like to get a hepatomegaly. So, okay. We good? That was a lot on pneumonia, but you see how, if you talk, well, it's just pneumonia and it's easy. But when you look at this, you start going, well, there's all these other things wrong. And so that, I think, is why imaging is difficult. It's because there are all these variations of normal, and there are all these ways that your eyes trick you. I've had requests for thoracic studies. This is a dog that's showing up for coughing and tachypnea, fairly acute. One of the other things, and I'll shut up, but one of the other things is that we do have some vet students, and there's people that their experience level kind of runs the gamut. And so for some of you may go, wow, this is really elementary or easy, and some of you may think it's hard. So don't worry, we'll get crunchy. We'll get a little spicy later. Okay, we'll break it out and put those of you that think you know what you're doing, we'll put you to work. So we got some ultrasound check for tamponade. So we've got some folks that are worried about tamponade. What's interesting too is I don't know what you guys are all going to say and what you guys are going to see. And so this is really helpful for me, because when I write reports, it's important to give you pertinent negatives or things that things that I that aren't there, but maybe somebody would think are there. So elevated trachea, mineralization of the trachea, enlarged heart, cardiomegaly, globoid vessels do not look enlarged. I would be checking pericarditis, liver small. Okay, so one of the things, so everybody's sort of catching on to the cardiac silhouette, right? So cardiac silhouette's enlarged. I would agree. When you see an enlarged cardiac silhouette, what's the next thing? The person that sent me this test, they have one question. They have probably one question. What's their question? If I don't even have a history and I see a big old cardiac silhouette, the next thing out of my mouth should be cardiomegaly, the dog, anybody? So there's a vote for vessel size. Yeah, I've been tricked by blood vessels. We talked about this last time. So I don't know. And if I'm in your clinic and I'm down the hall, I can kind of get this information. But if I'm in a teleradiology setting, there's a whole gap in information. And so it's possible the dog got furosemide prior to the study, and I don't know that. So Curtin is asking, Doc Curtin is asking, is there pulmonary edema? That's what they want to know. What's happened is big fat dog waddled in, he's blue, he can't breathe, he's coughing, owner's panicking, you hear a heart murmur, and you go, oh, is he have edema? So here's what we're going to do, not to beat a dead horse, but I'll tell you how I describe this, and then why I think some of the things that I think. So the cardiac silhouette is enlarged. It's characterized by a moderately, some people would say severe, left-sided cardiomegaly. So the cardiac silhouette goes up here. Okay, it's way up here. The rib is overlying it, so I'm not going to pretend like I can see it, but it's probably right here, right there, and then it's right here. It's too opaque right here. This is the left auricle, so we call it a left auricular bulge. So the cardiac silhouette is enlarged, characterized by a moderately enlarged left atrium, dorsal displacement of the thoracic trachea, a left auricular bulge, and a wide silhouette with increased sternal contact. The reason that I wouldn't describe this as globoid is because I still see a shape. I still see shapes. So I see that, I see that. And so, yes, it's kind of getting there. But when you have eccentric hypertrophy, so the dog has valvular and tricuspid valve disease, right? So you get reflux, and the excess volume, not pressure, volume reflux that's not being pumped out of the heart causes the chambers to stretch. And the eccentric hypertrophies make the cardiac silhouette look huge. Concentric hypertrophy, subaortic stenosis, all of our cats, pulmonic stenosis, those get concentric hypertrophy. So the lumen gets smaller, and so the heart gets big inside, if you will. And so you can have cardiac silhouettes that don't look that bad. So I think this is a pretty big cardiac silhouette. He's got right and left side. I think it's predominantly left-sided. I wouldn't be surprised if there's a decent amount of fat in this cardiac silhouette. There's all fat right here. There's a caudoventral mediastinal reflection right there. But what you want to do is figure out, does the dog have cardiogenic pulmonary edema? And last time we talked about drawing this line sort of through the cardiac silhouette like that. And then you go, do I think the lungs are normal or not normal? And so in this particular case, I think the lungs are not, I think they're abnormal. And so then you say, well, are they worse in the cranioventral lung or the caudodorsal lung? And in this particular case, I think they're worse in the caudodorsal lung. You can be faked out if the patient is expiratory, which this patient is. And you go, well, is this real? Is it not? Then you flip the dog over on the left side. You draw the line. You go, that doesn't look that bad. That looks a little bit more, busy. And then you flip the dog over and you go, interesting. There's a little too much. And you can use, he's rotated, right? Here's the sternum. You can use this. I think there may be a little bit of developing edema here, but that's too much. So if you go, this is a right lateral view, I believe it, fundus, left auricular bulge, caudoventral mediastinal reflection. You go, man, I think there's edema in the left caudal. We flip the dog over on the right lateral, which means I'm seeing predominantly the left caudal lung lobe, and it fits. So you go, I got a big heart, I got a caudodorsal lung pattern. This dog is in congestive heart failure, left-sided. If you thought this was tamponade, oftentimes you get a big old caudal vena cava, right? There's your caudal vena cava. Without, this one's kind of obscured. It doesn't look that big to me. Okay, with tamponade just increases the pressure of the pericardium, right, collapses the right side, and then you get basically right-sided heart failure. So you get your pleural effusion, you get your hepatomegaly, and you get peritoneal effusion. So I'll give it to you that you can't really see a ton of the cranial abdomen, but I would venture to say that liver is cute. It's almost too small. And so if we're going to talk about it, and there is probably some degree of backflow of congestion in the liver just from having right and left-sided tricuspid valve disease. So I'm going to go moderate to severe generalized, predominantly left-sided cardiomegaly with cardiogenic pulmonary edema, obesity, skimpy liver could be normal. Other things we talk about, microvascular dysplasia, extrahepatic portosystemic shunt, chronic hepatitis. Yeah, so these vessels, I think we've all been taught about these vessels. I guess what I would tell you to do is just, I've been burned on, well, the vessels don't look that bad. And so I wouldn't hang your hat on vessels, maybe one way or another. These vessels to me are totally normal. I agree, totally normal. Other things that could cause the vessels to be normal in a patient with heart failure, one would be, we just talked about, if the dog had previously been administered Lasix, especially IV Lasix prior to the images. But also I feel like dogs that have chronic heart failure, or dogs that have had heart failure, dogs that have been on chronic medication, sometimes will do weird things where their vessels won't get really big. So I wouldn't look at this dog and go, he's got a big old heart, he's got a caudodorsal lung pattern, but the vessels are fine. The lungs are not normal, right? So I think you got to go with the lungs over the vessels. One of the things that you could do, give them a little furosemide test, right? So again, I don't want to, part of the benefit of this is to see as many cases as possible and not to speak an hour on one case. But if everybody's ready to keep jamming about the cardiac silhouette, we can. But one of the things that you could do is, if you think that the dog, you're like, maybe the dog's in cardiac failure, left-sided congestive heart failure or not, you could do a furosemide trial. So if you give the dog Lasix, you should see clinical and radiographic improvement fairly quickly. So increased hydrostatic pressure from left-sided filling pressures can cause cardiogenic pulmonary edema, and the increased hydrostatic pressure leads to low protein fluid. So when you give a diuretic, the lymphatics in the interstitium, they pull that up pretty quickly, as opposed to, say, hemorrhage or pneumonia or some sort of exudative process. And so you will see a fairly rapid improvement in the course of 4 to 6 hours. You can see a little bit of improvement in that lung pattern. And so, you compare apples to apples. You take these, you go, I'm not sure. This is kind of faint. You can repeat it 4 to 6 hours after you give him IV Lasix, because unless his kidneys are trashed, the Lasix is not going to kill him, And so the other thing you could do is a DV view. UC Davis does a lot of, and maybe it's standard, probably is, they do 4 views on their chest. So DV, VD, left and right lateral. And that's, in my opinion, it's not a bad idea, because if you get into these cases of big heart, is he in failure, is he not, the DV view highlights the caudodorsal lung much better. And so you can pick off signs of low-grade failure that way. This, I thought maybe is the esophagus. It doesn't really look, there's the dorsal tracheal margin. So sometimes tracheal collapse can do weird things, like it can collapse and then rotate. So it collapses and then rotates this way. And so it can actually look bigger. And we can obviously go through some of those, but more detail over the caudodorsal lung pattern, please. Yeah. So, and I think this is worth talking about, Doc, because it's will really it'll get you out of trouble. So if you put up a study and I closed my eyes and I didn't look at it at all, and you said, is this cardiogenic or non-cardiogenic pulmonary edema? Just playing the odds based on the thousands of studies that I read every year, it's going to be cardiogenic edema. So the differentials for non-cardiogenic pulmonary edema, like electrocution, upper airway obstructed breathing, to include bulldogs, LARPAR, near drowning, seizures, those come in with that history, and you just go, okay, I think this is going to be a non-cardiogenic pulmonary edema. But when you look at a lung pattern, and if you've convinced yourself that you think that it is abnormal, you can then draw a line, sort of figuratively or literally, through the heart or the cardiac silhouette. And then you just kind of go, okay, is it worse here, cranioventral or caudodorsal? If it's worse caudodorsal, your little algorithm should go, okay, it's either cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. And then you go, okay, well, then the next question should be, is the cardiac silhouette too big? And then you look at the cardiac silhouette, and in this case, you're like, well, maybe it's globoid. I don't know, but it's kind of big. At least I got that. You could do the VHS, which the VHS is actually bigger on the right lateral view. So I'll just do this. I don't usually do this, but you kind of go like that. And then you go, I'm just doing this. 1, 2, 3, 4. This will just be, what are the numbers? 9.3. This cardiac silhouette's huge. The reason I don't do this a ton is because there's so many variations of this from different breeds, it just got to be a little bit overwhelming in terms of the numbers that you had to remember. Okay. But 2, 4, 6, 8, 10, 12, probably 13. So bulldogs can get up to 14, I think it's been reported. So that's why I don't put a lot of emphasis on the VHS. But you go, okay, caudodorsal lung pattern for sure. This bothers me. Even if the lung pattern's everywhere, where is it worse? Worse caudodorsally, it's going to be cardiogenic or non-cardiogenic 9 times out of 10. And then if you decide that the cardiac silhouette's big, maybe you don't think the cardiac silhouette's big, but you hear them, you escult the murmur, you got to go cardiogenic all the way. And you give the dog Lasix, and then you can maybe hold the dog 4 to 6 hours, repeat the RADs, love the DV view for low-grade failure. So if you're not really sure, and then you can see clinically or radiographically if you give them the IV loop diuretic. So if the cardiac silhouette is not large and you don't have a murmur and you have a caudodorsal lung pattern, then there are some unusual or less common causes of a lung pattern, like leptospirosis or inhaled foreign material or embolic pneumonia. But non-cardiogenic edema is sort of the next more common one in my experience. And so those you can also, I don't really know, depends on the inciting cause, but the non-cardiogenic ones are the ones where the cardiac silhouette's normal. The caveat to that is a ruptured cord. So ruptured chordae tendineae, oftentimes the lungs are really, really bad, and the cardiac silhouette is either normal or that left atrium is just sort of mildly enlarged, and it could give you a lot of trouble. But your breadcrumb, so to speak, is they've got a raging murmur, 4 or 5 out of 6. So that's one of those where you go, I'm just going to treat the lung pattern and I'm going to treat the heart murmur. So I don't know, Graham, if that helps. The vessels, I'm just like, the vessels are not the end all be all for me. Okay. So 3 views right here. I'm finding my timer. Give you a little bit of time. Left lateral view, VD view, and a right lateral view. Okay. So this dog's presented for like he's stretching his neck. The owner says he's like hacking and coughing, and he's lethargic. Anybody got anything? Okay. Nice. I like it. So I think what these two folks are what you do is you go, okay, this doesn't look normal. It's not normal. And then one of the things that you can do, this is one of those cases where you can use the Roentgen signs. So these Roentgen signs, what you want to do is you want to try to figure out, the big one is location, okay? Because you've identified that this is not, something's rotten in the state of Denmark, right? And so you go, where is it rotten? So this doesn't look normal. So what you don't want to do, and you probably have to do it for the format that we're using here, but what you could start with is you could say there's something abnormal in the chest. I mean, you could be that sort of broad, and then what you can try to do is use the Roentgen signs to narrow it down. So you go, there's something not right in this thorax, and then you go more specifically within the thorax, near the maybe dorsal and slightly caudal and caudal dorsal to the cardiac silhouette. Okay, so the location is important, but now you've just said that there's something wrong in the chest, and you've sort of given me where in the chest it's wrong, but we want to perhaps be more specific in terms of, is it in the lung, or is it in the mediastinum, or is it in the pleura? So you can be sort of that general, and so you go, okay, is this in the lung? It's possible this is in the lung. Is this in the mediastinum? Those structures tend to be on midline. So if this thing looks so bad on the lateral view, this thing, it's so quote unquote obvious, it's less obvious on the VD view. Now there's something here that's not normal. Okay, but boy, that lung looks very good, and that lung looks really good. So now I've got this opacity that's having a bit of a midline position. And so that should sort of alert you to a mediastinal origin. Yes, it could be lung and it's sort of on midline or whatever. So you go, okay, there's this increased opacity, sort of dorsal and extending caudal and dorsal to the cardiac silhouette. It's the location. So the margin, okay, the margin is sort of indistinct. I'm not going to pretend like I don't see it, but that margin is a little angular, right? You buy that. It's a little bit angular on that view. This view, I lose the margin. I lose the margin. Why? Because it's no longer surrounded by gas. So I've got this margin right here. So there's something that's got an angular margin. Is that surrounded by gas? So the location, the size, you could measure it. The shape, it seems oblong with a sort of angular caudal border. The opacity, it's soft tissue opaque. It's not metal. It's not mineral. I don't know. It looks like there's one. So the number, so the location, the margin, the number, the size, the shape, and the opacity. So we've got this sort of ovoid to somewhat angular soft tissue opaque structure that's dorsal and extends caudal dorsal to the cardiac silhouette period. It has a more of a midline position. On some of the views, there is gas in the vicinity of the structure, cranially and caudally. As Graham pointed out, there is a draping, or there's a soft tissue opacity that overlies sort of the carina and a portion of the thoracic trachea. Doc Leslie coming in with something stuck in the distal part of the esophagus. Dr. Curtin, esophageal foreign body. So for those of you, so this is an esophageal foreign body. And for those of you that were like, well, I didn't know this was an esophageal foreign body. One of the ways that you can get to the esophageal foreign body is you go, there's something not normal here, and you do the Roentgen signs, like we say. And so one of the things that you can do, the internist at the local clinic is going to be pissed, but screw them. What you do is you just give the dog a little bit of barium, little dollop, quarter size. You put the dog on the table, you throw it in the roof of its mouth, it swallows, you hammer off orthogonal 90-degree views, and then this barium is going to stick on this thing. And you go, oh, okay, let's turf it to another clinic. I got to go to bed. And then you're done. Okay. And the barium they clean the machine and it's fine. Okay. So this is an esophageal foreign body. And it is an emergency and you need to scope it. And yeah, this outpouching here. I can't remember if this was like a chronic one, but I don't usually see that bulge. Maybe it's chronic and it's developing a diverticulum, though with chronicity, I would expect pleural fluid, maybe some pneumonia. So liver's a little bit round. Sure. I kind of glossed over some of the other abnormalities on this one, but they won't scope it at your specialty clinic. All right. Well, then the dog will be in trouble. This dog won't make it, I don't think, without a scope. Got some disc disease and stuff like that. Okay, cool. Next case. Okay. 17-year-old female spayed indoor only cat. Heavy smokers, came in with a history of eating less, coughing from time to time, now breathing heavily. No fever. Rest of the exam is fine. Didn't do blood work. The heart ultrasound was fine. The abdominal ultrasound, which was cursory, was also fine. No abnormalities detected on that. Didn't see pleural effusion. Very concerned about the look on the VD radiograph. What's going on around the trachea? Thanks everyone for the input. Okay, I think there's a mass dorsally. Okay, so this VD view, let's walk through this. So some of the things that diaphragms are overrated. So the diaphragm, the overrated diaphragm, the cupula with the crura, the right and the left crura, and the cupula of the diaphragm, were an area of consternation for some of the folks on Facebook, where we were digging for this case. And so not too many of you have been bothered by the diaphragm, but there was a lot of concern about a diaphragmatic hernia. And so this is a cat, female spayed cat. I agree that the cranial abdomen, at least this is a kidney, this is the stomach, it's a left lateral view, which you get this sort of pyloric gas flow. There's colon. Important to know that the colon looks like it has formed feces. This is falciform fat. Don't forget that's an extra peritoneal structure, but you would potentially see some wisps or reduced serosal detail with peritoneal effusion. Left kidney, right kidney, okay? Spleen, stomach, right here, kind of goes up here, whips around duodenum there. Okay, so righty tighty, lefty loosey, spleen on the left. So we agree that this is the right lateral view. Okay, so what walking through this, I think it's difficult to look at this and go, oh, it's X. It's this particular disease. I don't think that the diaphragm, that there is a diaphragmatic hernia in this particular case. One of the things that you can look at is the costophrenic recess that's not often talked about. The costophrenic recess here, they should be parallel or symmetric rather. And so this one's way back here and this one's way up there. So they're asymmetric, which would suggest either this area has increased volume, pushing this one caudal, and or this side has reduced volume. And so what's happened in this particular case is this side is reduced in volume and this side is overinflated. It's increased in volume to try to compensate. And so this cute little cardiac silhouette, the cat's rotated, but it's a little bit more to the right of midline. But this is all opaque right here, and the cat sort of shifted. So I think what you should do when you look at this is you should say there's something resulting in underinflation of the right side. And then it's causing the diaphragm. I mean, if the space is not being filled by the aerated lung, the diaphragm, yes, the cat could have hemidiaphragm paralysis from a C5, C7 injury or previous pneumonia or trauma or something like that. But I think the more likely explanation is that there's a loss of volume on the right side of the chest, allowing this right side and central portion of the diaphragm to extend cranially and not a diaphragmatic hernia. And in all fairness, usually with a diaphragmatic hernia, if you had stuff like the liver or fat or intestine or the stomach extending cranially, it actually can push, the mediastinal, the cardiac, those structures into the contralateral chest. So everything seems to be just reduced in volume. And then Doc Amelia was right on the money. So what you look at besides the bad elbow OA and the back fat is you go, this trachea comes down, or the trachea, and it gets narrowed, and that's not normal. And then your eyes, you go, well, wait, there's a little too much here. It's not, I don't see all the borders, right? I see some border here, and then I kind of see it's kind of effaced here. So you go, okay, chest is abnormal. This is also not normal. That's way too opaque. Okay, so then you go, okay, there's this structure, too opaque, ill-defined borders dorsally, more well-defined borders ventrally. The more well-defined borders are outlined by gas. The ill-defined borders are not outlined by gas, suggesting they could be in the mediastinum. This structure, same thing. The borders aren't so clearly delineated as I would expect a purely pulmonary origin. But then when you come down here, you go, wow, this opacity. I guess first thing is that this radiograph is not centered appropriately, right? Centered right here. You should be centering on the cardiac silhouette. So that does give us a few fits. But this opacity up here is completely consolidated. Okay, so I don't really see a mass per se on this view. Yeah, that's a bit of a border. But when you take this view and you put this view together, you go, there is a mass here, and it's causing some sort of extraluminal compression of the trachea, sort of near the carina. And my guess is it may also be compressing the right craniolobar bronchus, potentially invading it. And so if you have, there's different types of atelectasis, but one of the forms of atelectasis would be an obstructive or resorptive atelectasis. So that tumor compresses or obstructs or invades any way that it is able to occlude the bronchial lumen. All of the downstream pulmonary gas will ultimately be resorbed, and then the lung will collapse. And so this is a mass. There is a poorly defined mass in this right cranial thorax that is causing collapse of the lung and allowing this to extend cranially. Now, if this was just involving the right cranial lung lobe, I would not expect this to be so dramatically pushed forward. So I wonder if this structure is also causing some sort of collapse. Would we be surprised if we did a CT and this was the tumor and it came in here and it was infiltrating or at least severely compressing the right caudal lobar bronchus, allowing the right caudal lobar bronchus to sort of be collapsed and this right crus and the cupula of the diaphragm to push forward. And then this has chronicity because this is sort of consolidated and because this is pushed up, but there's also this compensatory hyperinflation or overinflation of the contralateral lung. So there's multiple adjacent masses within the chest that are obstructing. They're compressing the trachea. They're obstructing probably the bronchi on the right lung. And so I would be worried about some sort of malignancy. Maybe this is a carcinoma with regional intrapulmonary mets. You're not seeing the border because of some degree of collapse. So fat for neoplasia. Speak to me, Graham. What's am I giving it? Am I going too fast? You got it. This is a hard rad. I don't expect you to look at this rad. This was just, there was some 30 or so comments on Facebook about this, and the doc sent it to me and said, what do you think? And so this is kind of what I think. I think there's a mass here, and I think there's another mass there. And I think it's chronic. It's probably cancer. And if you did a thoracic CT, I think this would obviously be much more obvious. You could ultrasound right there. You'd probably see hepatized or collapsed lung, potentially the mass. You could harpoon that. You'd have to get through about 4 inches of fat, but you could probably stick a needle in that. So that's that. I think the cat's got bad OA, no pleural fluid, no diaphragmatic hernia. It's eating well, eating very well. Any questions, concerns, comments? Oh, makes it confusing. Yeah, very confusing. I see. So the fat cat. Okay, maybe it's not neoplasia. Maybe it's I'm trying to think. I mean, could these be granulomas? I guess they could be granulomas. With chronic lower airway inflammation like feline asthma, you can get bronchoceles, which are these like, fluid-filled pockets that look like masses on rads, but they don't cause. Um, I don't know. I'm worried about this case because I don't see any other evidence that the cat has asthma. There's some nice looking lung. Even the part of the lung that's collapsed looks pretty good. So I don't see a ton of asthma. Mediastinal lipoma, nope, because it looks soft tissue opaque, not fat opaque. You can have some necrosis in the lipoma. TB, like the tracheobronchial lymph nodes, or like TB. Yeah, tuberculosis. I mean, tuberculosis, TB will cause some atypical stuff like this. I guess it's possible. I haven't really seen cases of TB. I don't know if you've seen a ton of cases of TB. Let's get one more. I'm going to put Doc Allen to the, let's see. Yes. What's up? She's
What's
real.
up?
What's up? Where are you located?
So I'm in Australia, in Queensland, near the beach. So you were right.
Near the beach. I don't even live near the beach. I think I've got something. Okay, so you've been coming for a couple of times, and you strike me as you're on it. You're sharp. So I'm not gonna. What do you want to do? Do you want a chest? You want an abdomen? You want to
whichever.
So here we go. So 3 views. I'll give you just a couple of minutes, and like you don't have to tell me maybe the diagnosis. I would just say, try to get as much of it you can. But that Mitchell mark, or this marker is not on anything special. Okay, so there's 3 views. There's a right lateral, a left lateral, and a VD view. So this animal has come in sort of collapsed and vomiting.
It's a dog, isn't it?
Sorry. It's a dog. Yeah. This is he's probably an older dog. I would say he's like an 11-year-old chondrodystrophic female spayed.
Well, I suppose like normally where you would see the fat opacity, like it's a soft tissue opacity ventrally.
Here?
Or soft tissue or fluid. Yeah, down there.
Yeah.
And I don't know, but if that's the spleen, more caudally, it's quite caudal.
Yeah.
And then kidneys look okay. There's feces in the colon, but there's something going up again with the spleen, like the splenic area.
Mm-hmm.
Just looks a bit odd.
So you're describing loss of scrotal detail. You're like, there's something rotten up here. There's too much. The normal fat, which would be sort of up here, looks a little. Yeah. And then you said this is the splenic tail, and there's a bit of a gap. So I like that thinking, because when you see wisps of fluid like this, which I agree with you, this is not normal. Then you kind of go, was there's like a raging pancreatitis, or why? And even to go simpler, loss of serosal detail, what could it be? It could be steatitis, or it could be peritoneal effusion. And is it sort of pushing the spleen away because it's really angry? I think that's possible. Okay, so the kidneys, I think we're okay. Also really good, like you did, you can compare abdominal serosal detail to retroperitoneal serosal detail to act as sort of like an internal control. Not so much a factor in this particular patient, but if you have an emaciated patient and you can't really see the spleen, the kidneys, it could be from a loss of, you may not have peritoneal effusion. So there's one kidney, there's the other kidney. Here's the liver. You see these sort of flamboyant costochondral junctions. It's probably from a dog that's chronically trying to breathe. I think the feces are great. Urinary bladder's right here. I think the spleen, it's got a little bit of a, this is it over here. To me, when I looked at this, I saw what you saw, which is the loss of serosal detail. The other thing, again, it's artifactual because, you're not able to zoom in and all that, but there is gas in places where it should not be. So this little nugget right here and that, but if you look, and you're going to be like, oh, this is bullshit. But there's like gas here. I don't know where that gas is, and I don't know where these little gas bubbles are. And so now you go, all right, so I've got a loss of serosal detail, and I've got these like little nuggets of gas here. That's probably in the stomach. This thing, I wondered if it was maybe a gastric foreign body, but foreign bodies don't really get little small gastric foreign bodies like this don't cause perfs. So what I said in the report was that this dog has a loss of abdominal serosal detail and it has a small volume pneumoperitoneum. And I felt like this was a little bit round, but I didn't think, would I be surprised if it was hyperplastic, because whatever's going on is not good. So when you see the loss of serosal detail with a few gas bubbles, you should go, septic abdomen, he's perf something. And so that's what this ended up being. I think there was an intestinal mass that had perfed. I can't see the intestinal mass. So when you see this, you could take it straight away to surgery. If you didn't see the gas, I think you could get there anyway, because you go, all right, well, I was able to identify this is not normal. And I think it was probably peritoneal effusion or steatitis. Maybe I thought this was either a ruptured splenic mass because this was a little bit bulbous and it was displaced. Or maybe it was really bad pancreatitis. Whatever it was, this was the clue that set you on the right path, which is that I probably need to do a sonogram. And then when you do the sonogram, you're probably not going to see the gas because there's not a ton of it. And you have to sort of be specifically looking for it. And then you're going to be like, I can't find the damn splenic mass. But you'll find the fluid, and then you'll stick it, and then you'll see the bugs. And then you're like, well, this is not good, and then you'll scratch your head and you won't know. And then maybe you stumble on, if you're good with the ultrasound probe, you'll stumble on the mass. Sometimes these can be gastric masses, and the dog's panting, he's dying, there's gas, you can't find it. So I think this case is, you would have been fine on the case because you would have ultimately. This is not that easy to see for some people. So I think seeing that loss of serosal detail immediately pushes you towards the ultrasound. You find the fluid, you confirm it's septic, and then you're like, well, I don't know why, but we got to cut it. And then then you leave it to the surgeon to do it. So I don't know if that helps or if that was a good case. Anybody else? Yeah, penetration of the gut. I think with gastric perforations, there tends to be a ton of gas. This is a small amount. This is very tiny. And I didn't expect you to find it. I just thought it was a cool case because once you see the peritoneal fluid, you go, well, maybe. And you would have had other things on physical, right? Severe abdominal pain. It would have had a fever. I mean, it would have. But sometimes I think from an imaging point of view, it's nice to not have that because it makes you focus on actually trying to look at the images. So, all right, cool. Well, cool. All right. Well, you enjoy the beach. Don't get sunburned, or do. I don't know. But all right. Well, I think I can remove
Boot me
you.
off. Thank you.
I think I can boot you off. Yeah. Cheers. Thanks, Amelia.
Okay.
Talk to you soon. Okay. Bye.
Bye.
Yeah. I think that's fine. I feel like I was thinking pancreatitis until you mentioned the gas. So the gas, I think, is from a perf. Something in the GI tract has perforated. And so it's either the colon, the small intestine, or the stomach. Sometimes you can get like necrotic liver masses that will have hepatobiliary gas, and that can lead to a septic abdomen. But you would sort of look up here and go, I don't really see, that seems to be in the stomach. That seems to be in the stomach. Not seems to be, it is. The stomach kind of comes around here, so that's probably the pylorus on the left lateral view. So, and I didn't have one. Maybe I can show you next time. A lot of times you'll see the gas, it'll hide up here, and so you see this arc. But yeah, I don't think what you need to, I think, take away is all the things that we talked about, but it's this loss of serosal detail that will push you into this idea of I need to find out what this is now. I need another test now, and get an ultrasound, try to find the fluid, and confirm that he's septic. So this was a perforated intestinal mass. All right. Are there any particular sites that gas would tend to accumulate for you to see on ultrasound? So I think ultrasound, it's supposed to be more sensitive, but you will be surprised at how easily it is to miss it. So the reason that you'll miss it is, one, you're not looking for it, and two, it's so far up in your near field, usually you're looking deeper. So and you will have lots of hyperechoic interfaces in the superficial tissues related to the body wall fat and fascial planes and muscle and the air being trapped from the probe. And so there are all these bright interdigitating lines that are really in your near field. And just under the peritoneal lining, which is also hyperechoic fat, is you'll get gas. And sometimes it won't sit still because you'll push and you'll squirt it. And so if you have little tiny bits of gas, they can be hard to they can be hard to find. So, but I think you bring your focal zone up into the near field and you look right under that body wall and you'll see it. And it tends to accumulate up near if you put this dog on its back, it'll accumulate up here. So it'll tend to, if you put the dog on its back to scan it, I always scan the dog in the back. There's a foreign body in there. But if you put the dog in the back, it likes to hide up here. And so you will find it, you're not going to find it zooming around back here. It goes up to the highest. When you put the dog on the back, the highest spot is going to be up under the xiphoid liver. So you'll find it when you're up in that liver stomach area. Yeah. Any tips on dismissing something like the gas? Yeah, I think so. The tips for the gas are, I will tell you, this is a small amount. So this is not a lot. One of the things that you'll notice is that these gas that's tubular, that has tubular shapes, is in the gut. This is a little bit more angular and it's sitting over the kidney. But this gas, and to be fair, this probably isn't the best teaching case because it is so small, but that is gas. And I don't see a loop over there. There's the spleen, there's the colon, and that's probably another gas bubble, and that's another gas bubble. So, I didn't expect you guys to see that there was a pneumoperitoneum. I was hoping you would see that there's a loss of serosal detail. And I think, Graham, even if I think, I think just sort of objectively, this gas, it will tend to go in places where you don't have small intestine. The larger amount of gas, it will actually come right up here. This is gas. This is gas. That's peritoneal gas that's superimposed with the retroperitoneal space, and it's a bit angular. But that sucker, for me, I was like, ooh, loss of serosal detail. Ooh, that's interesting. There's no gut up there. There's no gut. That's interesting. That's interesting. But then once you find that, you go, uh-oh, now it's game on. I don't know if that helps, but Samantha, Doc, thanks for showing up. All right, my daughter turned 5 today. I'm gonna go home, read a book, tuck her in. And I hope you guys have a good week. This will go to YouTube here probably in a couple of days. DACVR, I'll send you your free subscription. I'll probably do another subscription next week. So hopefully you guys have a good week, and I'll talk to you soon. Bye.